Hero Podcast. Igniting both the art and the science of functional medicine. Here's your host, Dr. Brad Watts.
Nutrition Heroes, welcome to your podcast, another episode of the Nutrition Hero Podcast. Dr. Brad, glad to be with you here, smiling like a fool today because I'm a tortured Minnesota Vikings fan. And if you were watching the Vikings game last night, you'll note that they won with no time remaining on what I would consider to be a miraculous play, something that should have never happened, and you got to feel bad for the other team, but not too bad because, I'm a Vikings fan. So anyway, thank you for letting me gloat about that for just a few moments. You didn't really have a choice, did you? But thank you for tolerating it. So I got to just say this one thing here before we move on and talk about some of the other housekeeping issues. My goodness, people, I was in 8th grade when Gary Anderson missed a field goal to the left, crushing my Super Bowl dreams, right? And then, decade later, oh my goodness, what's worse than not being in the Super Bowl in your lifetime? Having to borrow the hated players from your childhood to get there, first of all, Brett Favre, and then they mess it up and blow their other chances. Oh my goodness. So, tortured Vikings fan here, and I just got to say that my heart was racing so much yesterday that I had to sit down. And also, on top of that, I'm not a yeller, right? But I yelled so loud when that last play happened. I was doing play for somebody over the phone who was traveling, and oh my goodness. I yelled so loud that my kids started crying because they thought I was angry. Like, they've never seen me that angry, right? But I wasn't angry. I was excited, and so I had to explain to them what it meant, right? Meat, potatoes, and Vikings. That's just kind of how you grow up in Minnesota. So anyway, thank you for humoring me, and you just better cheer, right? I'm looking for your support here, people. Skol, right? All right, we'll move on to the topics at hand today. Emails. I've been getting a ton of emails about continuing education. Where do I suggest you go, etc. And obviously, I'm going to recommend that you come hear me speak. It's the biogenetics blood chemistry experience. If you have not, I promise you've not ever been to a blood chemistry course quite like it. And it's more about applications for your patients rather than sitting in a situation where you're just learning about individual markers and how high, how low they should be. Yeah, I'll give you that information, and it's applicable, but even more so, the patient application is something that we really strived to put together in a way that you can digest and take into clinical practice the next day. So I enjoy it, and going through seminar after seminar as I'm cutting my teeth in functional medicine. One of the things that I loved was the patient application. Tell me the story, tell me how to, tell me what to do and when and why, rather than just a set of rigid rules. And so you have to know the rules, right? You have to know them, but it's even more important to know how to apply them. So very cool. So if you haven't been to a biogenetics blood chemistry experience yet, part 1, obviously sign up for it. If you haven't been to part 2, and I know you haven't been because I haven't taught it yet, it's coming up this year in 2018. Make sure you get on top of that. You can email Kari, K-A-R-I-I, Kari, at biogenetics.com, and she will get you organized with all of that information. Kari, K-A-R-I-I, at biogenetics.com. So I get excited about it. I love teaching in this format. It's a lot of words, but it's also a lot of, for me, teaching is basically all of the emotion that you experience as a provider. Being able to get that out in a single setting is something that I value highly, because what you're able to do is you're able to put thousands of patient interactions into a couple of days and give them to people that have had maybe thousands more than me, right? And reinforce the emotions that they're feeling, the decisions that they've made in clinical practice. But also, if you're somebody that hasn't had 20 visits yet in a functional medicine setting, it's a way for you to experience and get inspired to take this functional medicine message and participate in this movement that's happening in the United States today with functional medicine, and to just put yourself on the front lines in FM and be able to say, here's what I know works, right? And why? Because there are thousands and thousands of patient interactions standing behind the words that you're hearing. And so anyway, I get so passionate about it, and it's fun. It's fun. So, all right. So that's the first thing that I would recommend. Secondly, there is a doctor that has an online education portal that I am going to talk about here. He does not know that I'm going to talk about this, right? But I do have a link in the show notes to Dr. Ron Grisanti's website. And Dr. Grisanti has a program called Functional Medicine University that I went through back in the day here, maybe a couple of years ago now, to get more of a formalized education. And I will say that the program itself was made up of 11 to 12 modules, 12 I think at the time, and they're always expanding it, right? So even now, after graduating the program, I'm still getting emails and tools and resources and new research, and it's amazing the amount of data that's actually being filtered through there. But one of the things that I found to be the most critical, the most important with the Functional Medicine University education is the amount of research that backs up what you're learning. And it's awesome. This day and age, when you have an opportunity to stand on the shoulders of people that have spent hours and hours and tons of money on the research of functional medicine principles, on the research of food as medicine, on the research of herbs as medicine, it's amazing. It's amazing. So I would highly suggest, strongly suggest, and may I say that I would, if you went through any other education for functional medicine, I would say that just from what I've seen, I would say that you are missing out if you don't go through Dr. Grisanti's education. So anyway, click the link in the podcast notes below. It'll take you to his website, and go ahead and get yourself registered. I think I got 206 hours or 207 hours of continuing education that I was able to turn into my board and say, hey, I did 200 hours this year of education when they require 20, right? And that's one, it's nice to be able to do that. But number two, it's always nice to be able to put that on their radar as a provider under the jurisdiction of a board. So anyway, so click the link in the show notes below and it'll take you there and should be set. Also, today, getting into the meat of what we're going to go through today, I don't even know what the word is for all of you emotional intelligence gurus. Joyful does not quite put it together for me, but what I am about to show you today is an interview with one of the world's foremost authorities in the cardiovascular realm, and he is the director of the Hypertension Institute at the Vanderbilt University School of Medicine. His name is Dr. Mark Houston, and Dr. Houston is a giant in the cardiovascular world. He is a giant in the functional medicine world, but even more so, he's a really nice guy. And he was able to sit down with us and spend 25 to 30 minutes, and which I appreciated so much, talking about his book entitled What Your Doctor May Not Tell You About Heart Disease. What your doctor may not tell you about heart disease. What's really cool, you guys, is his book flies in the face of so many of the standard answers in medicine today. And this gentleman is a medical doctor. He is, as I said, the director of the Hypertension Institute, and he's standing on 20 years of research, which is phenomenal, number one. But then number two, he's in a position of authority when it comes to patient application with this research. And so he'll tell you more about that, been getting this stuff out. But he founded the Hypertension Institute in 1995, and he's an internist and a hypertension cardiovascular specialist. When we look at the applications that he's going to deliver for you today on this podcast recording, we get into nutrition, we get into exercise, we get into the nitty-gritty when it comes to what are the recommendations that everybody should be following. He also talks about cholesterol in a way that I think you'll find entertaining. I just appreciate Dr. Mark Houston for taking an opportunity to come hang out with us. Incidentally, if you want more education on cardiovascular health, he actually has some programs that you can enroll in for continuing ed through a4m.com, a4m.com. In the cardiovascular modules, Dr. Mark Houston will be teaching those himself. So I was able to meet Dr. Houston in person a couple of weeks back before the holidays and all of that. And I met him at an A4M conference, incidentally, and was introduced to him by a colleague, which I very much appreciate. You know who you are. It's an opportunity for functional medicine providers to hear what's happening at the pinnacle of cardiovascular treatment today, right? And then what I want you to get out of this podcast, what I hope you hear in this podcast is something to the effect of, hey, here's a guy at the pinnacle, at the top of the pile in cardiovascular medicine, in preventative cardiovascular medicine. And what's he doing? He's doing the same stuff that you have access to in your functional medicine practice, right? At the pinnacle. And so that should put a smile on your face in a way that just gives you an opportunity to be thankful, one, for what he's doing, but then secondly, it's happening. Functional medicine is taking over healthcare in the United States today. It's awesome. So without any further ado, I'm going to introduce to you Dr. Mark Houston. All right. Welcome to the Nutrition Hero podcast, Dr. Mark Houston. Thank you for being with us today. I appreciate your time, sir. How are you?
Thank you, Brad. I'm glad to be on the program with you. Thanks, sir.
Very good. So, Dr. Houston, I would like to start talking about one of your books today, one that I've recently read called What Your Doctor May Not Tell You About Heart Disease. And by the way, I have to say bravo first and foremost.
Thank you.
I like your approach, and I also like it reads like it's a reflection of your personality. So that's pretty awesome.
Okay, excellent. All right.
So, yeah. One of the things in your book, Doctor, that our listenership here I know is going to be interested in is discovering the causes of heart disease. And I just got to ask, how many years were you practicing before you started to put this information together in such a way?
It took me about probably 20 years of research and clinical practice and a lot of extensive reading and publications to get this concept formulated with good science behind it, and then take that science and apply it to my practice, but also do some prospective double-blind research trials to document that what we were saying actually worked. So I feel very comfortable now based on all those years of experience, and what I put in the book is very accurate.
Yes, very cool. One of the things you had talked about in the book is a primary cause. And one of the myths that you presented in the book is that cholesterol may not actually be the primary cause of heart disease. And how has that been received in your field of study, Doctor?
Well, you want to be careful how you define when you say those sort of earth-shattering comments,
right.
so that people really understand what you're saying. So my real message is that we've concentrated on heart disease with what I call a cholesterol-centric approach, and because of that, we've ignored a lot of the other obvious risk factors for heart disease. And you can say, well, we've done pretty good by getting cholesterol down using different types of therapies, but that still leaves 50% of the people in a hospital coming in with acute myocardial infarction or heart attack who have normal cholesterols, and they're still having heart attacks. So why is that? Why do we have this big coronary heart disease gap where people are still having heart attacks with normal cholesterol? Which brings us to the real important question is, number one, have we been checking the right types of cholesterol using advanced lipid testing? And second, are we using the right drugs and or nutrients or lifestyle to treat the cholesterol? And then the biggest part of the gap is we have ignored partly the other 399 risk factors that contribute to heart disease that need to be not only checked, but checked appropriately.
Right. Right. And I recognize in your book you talk about 400, close to 400 anyway, risk factors, which is amazing. Number one, that you're able to identify them, but then number two, are there actually tests for each of these risk factors, doctor?
Yes, what I have done is try to give them the big picture, which is their 400, and honestly doesn't even include some of the newer things with genetics and genetic testing that we're doing. But within those 400, you can identify about 25 or 30 that I call the top modifiable risk factors, and even most of those are not being checked in a traditional internal medicine or cardiovascular practice. But what's really disturbing, though, is if you look at the myth that's out there, which says just concentrate on the top 5 risk factors and get those controlled. Well, what are the top 5? Well, blood pressure, cholesterol, diabetes, don't smoke, and don't get fat. Well, the problem is most of those, 4 out of the 5, that is excluding the smoking thing, which everybody would say don't smoke, have been misdefined because we don't use the appropriate test to define the problem we're trying to treat, and therefore we don't treat it correctly. 24-hour blood pressure monitors, for example, should be done routinely for diagnosing and treating hypertension, advanced lipid testing for cholesterol and dyslipidemia. And we have to redefine the entire diabetes spectrum, related to high blood sugar, metabolic syndrome, and then type 1 or type 2 diabetes. So just take those 3 right there and define them correctly. If we did that alone, we would take that coronary heart disease gap down from 50% maybe down to less than 25%. And the rest of it's due to everything else that's not being checked.
Wow. So with what you're doing right now, doctor, not just all the research, but actually treating patients, obviously at the Hypertension Institute, and educating other doctors, how much of your time is spent getting the message out versus treating your community?
Well, the good thing is we've been doing this long enough now that we've gotten the message out pretty good to most of the practitioners who come to our symposiums. Most of the patients who come to see me have become motivated by looking on my website, or they've heard about me in different arenas. So they come in with a wholly different attitude about what they want to do to treat themselves. So they follow the program without having to be cajoled into please do this, please do that.
So is there a specific style of diet that you're recommending as you're teaching these symposiums?
Yes. The best data actually is with the Mediterranean diet. It's called Traditional Mediterranean Diet, or TMD. That's got the best clinical data for heart disease reduction, stroke reduction, diabetes reduction, and other things. And we combine that with a very low glycemic diet, reduce refined carbohydrates and sugars to very low levels, and get rid of most of the bad fats, particularly trans fats, and some, but not all, the saturated fats, and then try to incorporate a really good content of omega-3 fatty acids and monounsaturated fats, which are things like olive oil and nuts. Balance the protein, balance the carbs, balance the fats, and then get people to get their body weight, visceral fat, body fat under control, exercise every day, get plenty of sleep. I mean, here's a little known fact. I think if you tell patients, they're just absolutely blown away with this data, is that 70% of heart disease can be prevented by what I just said. The right type of diet, exercise, weight reduction, and not smoking.
70%?
The other 30%. 70% can be reduced just by doing those things.
Yeah. Wow. Very cool. Your message then obviously carries some weight when you have so much research behind you. what part of that do you enjoy the most? Is it doing the research? Is it analyzing the data? Or is it communicating this to the public, doctor?
I really enjoy all of it, but I guess my real passion is the teaching. Teaching other practitioners, particularly how to do this correctly. Also talking to the lay public, and you do that in a lot of ways. You can do it at seminars. You can do it through medical lay books. You can do it through peer-reviewed medical articles in the literature, TV shows, radio shows like we're doing with you. All these things help to get that message out, and I think if we keep doing this, we can really change the course of heart disease in this country and try to get a better handle on it, because we've really reached a sort of a flat line here with our ability to reduce heart disease, and we've got to make some big changes in what we're doing to really get to a lower level of risk.
What do you see coming down the pike here as being that next thing, the next vehicle allowing that to happen?
Well, some of the things we're already doing, actually, we do a lot of advanced, not only advanced blood tests, but advanced cardiovascular tests where we can measure literally everything in the cardiovascular system. Calcium in the heart, endothelial function, arterial compliance and elasticity, genetic testing, genetic gene expression. And so we look at their genomics and then try to take the bad genes and turn them off, take the good genes, turn them on through different lifestyle, supplements, nutrition, supplement drugs, combinations. And all these things will really reduce risk very quickly. I mean, we can identify changes in many of these parameters within 3 to 6 months.
Wow. Very cool. What one of the things that is a buzz, especially this time of the year, when people are talking about losing weight and trying to walk away from obesity, so to speak, that type of thing, are detoxifications or detox diets and that style of thing. In the research that you've been able to go through, is there room for detoxification or supporting detox pathways in patients with cardiovascular disease?
Absolutely. Most of us are what I call toxic burdens. Over our lifetime, we've accumulated all types of things like heavy metals and pesticides, organocides. We've got not necessarily all communities, but many communities have bad water. There's air pollution. All these things contribute to cardiovascular disease. So if you do appropriate tests, try to identify that toxic burden and then clean it up with, detoxification protocols, you're going to make the body able to handle the program you put it on a lot better, because things don't get sort of backed up, so to speak, and the progressiveness and beneficial effects of the program that you use for cardiovascular health is much more efficacious.
Absolutely. That's awesome. One of the things that I appreciate about reading your book is the approach to nutrition that you had, and not taking a blatant stance on something before actually looking into it. And I think that's pretty awesome. So I just have to commend you on that, Doctor.
Well, yeah. And I guess if I had a really great message for your listeners,
yes,
we can boil down this whole concept of the revolutionary changes in cardiovascular medicine into the following statement. There's an infinite number of insults to the vascular system, but there's only 3 finite responses to those insults. They are inflammation, oxidative stress, and vascular immune dysfunction. So what we do is we identify those 3 finite responses with different lab tests. Then we track back in a reverse fashion to find out what's setting off those finite responses. What are the myriad insults that are out there? And this could be lots of things. Like I said, there's almost an infinite number of insults. And you find what those insults are, you remove the insults, treat the downstream mediators of those insults, and hopefully then reduce the outcome, which is those 3 finite responses, which are really the end product that cause coronary heart disease and heart attacks and heart failure. So that's the real difference, I think, in what we're doing, rather than this old approach, which is, let's just look at the top 5 risk factors, and we don't even define those correctly. And then we give you a drug or something to try to get it under control, and we never get an optimal reduction in heart disease.
Right. Right. So what have you seen from a nutritional approach, like you're talking about here, moving from the past, which is we talk about like nitric oxide or endothelial dysfunction and nitroglycerin, if anybody's listening and remembers that from back in the day. When we talk about nitroglycerin versus some of the tools that you have available now that are allowing the endothelium to begin to produce nitric oxide more appropriately, can you touch on that transition, Doctor?
Certainly. The gentleman physician who won the Nobel Prize in 1996 is the one who discovered nitric oxide, which is one of the most amazing products the human body makes to produce a healthy vascular system, a healthy heart, to reduce heart attacks, heart failure, lower blood pressure, and many other things. So one of the things we try to do is increase the bioavailability of nitric oxide in the body. So that's done with proper nutrition, which is a lot of dark green leafy vegetables, at least 8 to 10 servings of dark green leafy vegetables and other vegetables per day, along with some fruits, particularly berries. All of those things have compounds that will increase the body's production of nitrites, which are converted to nitric oxide. And we use a lot of supplements also to improve NO production. One of the best is beetroot extract, and one of the companies that makes that is called Neo 40, and Neo 40 is a wafer. You chew it up twice a day, and dramatic increases in nitric oxide levels. And we've done clinical trials with that, and we see improvement in the endothelial function, lowers blood pressure, improves vascular function, and so forth. And there's a lot of other things that you can use as well. There's a whole list of supplements that raise nitric oxide in various ways. Polyphenols, monounsaturated fats, omega-3 fatty acids, coenzyme Q10. There's a list goes on and on. But for your listeners, if you just do the dark green leafy vegetables, fruit and vegetable intake, and maybe some Neo 40, you're going to cover a lot of your nitric oxide issues.
That's awesome. So we just talked to Dr. Nathan Bryan, one of the gentlemen researching nitric oxide with that company, and so very cool, very cool. Doctor, when you talk about weight loss with patients and you talk about maintaining weight loss, sometimes patients tend to go on that yo-yo scale, right? They'll lose 50 pounds, then gain 35 back, that type of thing. What are some of the strategies that you find in clinical practice that are helpful for people to maintain that which they've been working so hard for?
First of all, we never use the word diet. We use lifelong nutrition change, because people have to understand that this is not a quick fix, and then they have to lose the weight and the body fat slowly and keep it off and not do the yo-yo deal. So we have various types of nutritional consultations. We have a full-time nutritionist in the office. We combine proper nutrition with proper exercise, proper sleep habits to get people jump-started. We also often use what's called the fasting mimicking diet, which has a great ability to sort of reset the visceral fat problem. We measure body fat and visceral fat. We don't go by weight per se because that's very deceiving. And tell people, even though your body weight may not be changing quickly, it's the fat that's dropping because maybe you're increasing your lean muscle mass, and that's going to weigh more. And we tell people to lose it slowly. 2 pounds a week is generally a nice weight to shoot for. Sometimes you can lose more, but if you lose it too fast, you're going to end up in a situation where you're probably not going to be as healthy, and it's not going to be sustainable either.
Right. One of the things that in your book you talked about is a stress response, or the stress that's associated with cardiovascular conditions. That obviously plays into the account that I've seen in my practice with patients in weight loss, what are some of the things that you recommend for patients to manage different stressors in their life?
Well, probably the best single thing you can do is get 8 hours of sleep every night and exercise. If you get if you get uninterrupted sleep and you get about an hour of exercise daily, that's probably the two best things to get your stress level down, your cortisol levels down. And then if you can find some time to do some deep breathing exercises and some meditation, that just adds another level of reduction in stress and decreases, your sympathetic response and enhances your parasympathetic response.
Absolutely. Your hour of exercise on a daily basis, what type of exercise are you recommending, and what's that look like in your recommendation typically?
Yeah, in the book that you mentioned, what your doctor does not tell you about heart disease, I have 2 pages, or 2 chapters actually, on how to exercise appropriately. And the bottom line is you want to do about 40 minutes of resistance training and about 20 minutes of aerobics, which is primarily interval training. That gives you an hour a day, and you always do resistance before aerobics. And if you do that, what you're going to do is increase lean muscle mass, decrease body fat, and enhance aerobic cardiovascular conditioning. And that is what has been shown to reduce cardiovascular risk with heart attacks, strokes, and congestive heart failure. But you also have a tremendous change in your body composition by doing so.
Yeah, see, that's amazing, because I think there's a misnomer in the lay public specifically that, you're going to spend an hour on the treadmill every day, and if you have time, do a few push-ups. So
Right.
that's a 180 right there, what you just present. That's really cool, though. So
what happens is as you get older, if you keep just doing aerobic exercise, you're going to actually lose lean muscle mass, so your body fat percent actually goes up. And that's not a good thing. That's why you've got to do the resistance training as a predominant part of that program.
Absolutely. I was just preparing a presentation here earlier today that basically reading some research that shows reactive oxygen species responding to the actual putting a demand on the mitochondria versus not, right? Versus just relaxing. You would think reactive oxygen species would chill out, but it's the opposite, and that's really interesting. It goes hand in hand with what you're saying here, so that's pretty cool.
Yeah.
So, all right. Doctor, with one of the things that I see in clinical practice are children, like this heart disease thing in kids that is starting with obesity at, under 10 years old. You see little kids that have obesity, and it's setting them on a path that's probably pretty confusing for them. But then secondly, a path towards heart disease at a really young age. What do you see taking place in the culture right now that's moving us towards or away from that, from your perspective, sitting on top of the research pile, so to speak?
I think we're going to have a second wave of coronary heart disease in this country. We had it, up, then down, then stable. Now I think it's going to head back up again because we've got an epidemic of obese children who are getting diabetes earlier, their cholesterol is going up early, they're getting hypertension. I mean, I've got 13-year-old kids that are already taking drugs for these 3 risk factors, and sometime even younger.
Wow.
I don't see, pediatric patients, but I see the children of adults, but I don't start seeing them until about age 13. So I know it's at age 13, but I have pediatric colleagues who tell me that they're seeing it even younger ages. So those people are going to have problems earlier even than we've identified in the past. And now we've taken it back even to in utero, where the mothers are having all kinds of problems during the gestation period, and so they're delivering children that are just a mess with cardiovascular problems and obesity, and it's really sad because we've got so many things we can do to stop this epidemic, but the sedentary lifestyle, the bad diet, the lack of exercise, and the epigenetics and genetics that affect the mother and now the fetus are being seen in very young children.
Wow. So the style of care that you're giving adults right now, are there any clinics like this in the United States that are focusing on cardiovascular issues with children?
There may be, but I don't really keep up with the young population studies and centers that do that. But there's got to be a lot of centers across the U.S. that are looking at these cardiovascular risk in the pediatric population, and that's where a lot of this data is coming from.
Gotcha. So one of the things that we see with obesity, just to kind of dovetail off of childhood obesity here, is surgical intervention. And the surgical intervention, I've seen studies that show the reduction in the risk of diabetes and the complications that go with it and that type of thing. Are there any correlations with heart disease after surgical intervention for obesity?
Well, one of the problems after surgical intervention is you get all kind of micronutrient deficiencies and protein malabsorption, depending on what type of surgery is done. And obviously, there's a population that just doesn't respond to anything, and they benefit from bariatric surgery. But I try to get patients to realize that if we can approach this without surgery, lifetime complications will be less. They'll be a lot happier. They'll be healthier. It's like we've got a bad problem. Let's create a bad solution. So I don't like to do that.
Right. Gotcha. That you'll have to coin that, doctor. A bad problem with a bad solution. So, yeah. All right, Doc. What's your take on juicing? What's your take on juicing?
Yeah, that's very popular. A lot of things get in the literature that are so scientific basis. Juicing is really not very appropriate, and I'll tell you why. When you juice, you get all the fiber out, and sometimes a lot of the nutrients go out as well. And so you're not getting just the juice, which is very high glycemic index. And if you do that all day, particularly if you're prone to insulin resistance or diabetes or you're overweight, you can start having issues with your blood sugar and glycemic response, your insulin spikes. That's not healthy. You're better off just, if you want to do a blender of something, just throw it in there and eat what's in there. Don't squeeze out the fiber and all the goodies. Get you something that mashes it all up like you want it. If you want to do that with some kind of fruit vegetable porridge, but don't start throwing stuff out. It's better to eat the whole fruit. It's better to eat the whole vegetable than start trying to figure out what part you think is bad, what part you think is good.
That's wonderful. I'm so happy that you had that opinion with this, doctor. So that's pretty good. When you look at taking a whole food and then disassembling it and taking out the parts of it that are controlling the glycemic, load, et cetera, that's a recipe for disaster, I would find most of the time, just in clinical practice, but also in the clinical literature. So that's man, interesting.
I mean, I have a magic bullet, which what you put in is what you get out, and sometimes I just decide I want to just throw a bunch of stuff together and have a soup, but it's all in there.
That's exactly right. Yeah. So, all right, doctor, what is if we could get a couple of takeaways here? What are the top 3 things that a provider, a natural healthcare provider, a functional medicine provider, a nutritionist, et cetera, what are the top 3 things that we can do just to point our patients in the right direction from a cardiovascular health perspective?
Number 1 is teach them proper nutrition. If you could do it on your own or with handouts or CDs or with a nutritionist, teach them proper nutrition. Number 2, teach them proper exercise. We've talked about how to do that. And number 3, get 8 hours of sleep. If you get 9.5 or 7.5, you're going to have more problems than if you get 8. So that's my top 3. And then, obviously there's others you need to throw into the pot too. You don't want to smoke. You don't want to get fat. All those sort of things.
Right. Wow. So Doctor, appreciate your opinion on the subject matter here, especially with your background and your history. And once again, been listening to Dr. Mark Houston out of the Hypertension Institute and also author of the book, What Your Doctor May Not Tell You About Cardiovascular Disease, Heart Disease. Doctor, I appreciate your time today, and thank you for spending...
My pleasure, Brad.
Oh, my goodness. Thank you for spending your attention with us here at the Nutrition Hero Podcast. We appreciate you, sir.
My pleasure. Thanks so much for being on your program.